respectful of all of you who are timely in joining us today. I'm Denise Rankin. I'm an appointed member of the Sarcoma Patient Euronet Board of Directors, and I'm really pleased to welcome all of you to this session on soft tissue sarcoma today. It's so good to see so many of you here with us. A bit of background for those of you not familiar with the Sarcoma Patient Euronet, SPAEN. This is a collaborative association, and it was formed and founded by 11 European GIST, desmoid, and sarcoma advocacy and support groups in 2009 in Germany. And in close collaboration with experts, the healthcare industry, and other stakeholders, SPAEN has focused its efforts towards improving treatment and care for GIST, desmoid, and sarcoma patients by providing information and support, as well as increasing visibility of sarcomas with the policymakers and the public. So aligning with these really important goals of SPAEN, we're really pleased to host this program today and welcome this expert panel who will be bringing us up to date on medical and scientific highlights in soft tissue sarcoma from their expert perspective of areas of pathology, medical oncology, orthopedic surgery, and radiation oncology. For those of you who are dealing with the sarcoma, you know how important it is to have several experts working together to develop and deliver care. So it is so fitting that we would today have this multidisciplinary group with us here. So let me begin by introducing our esteemed panel. We're delighted to have Professor Bernadette Liegl-Atzwanger bringing the perspective for sarcoma pathology. She's a professor of pathology at Medical University in Graz, Austria. She's engaged in basic as well as clinical research to better understand the pathogenesis, or how tumors form, and tumor heterogeneity of sarcomas, with the goal of establishing alternative therapy concepts. We welcome you, Professor Liegl-Atzwanger. I'm also pleased to welcome Dr. Silvia Stacchiotti, a medical oncologist who works in the adult mesenchymal and rare tumor medical treatment unit at the Istituto Nazionale Tumori in Milano, Italy. Her clinical and research activities focus on adult soft tissue and bone sarcomas, including GIST. She's involved in all the institutional research activities in sarcoma, with a special focus on the very uncommon subtypes. Additionally, she collaborates globally with sarcoma colleagues around the world to advance treatment for sarcoma. Welcome, Dr. Stacchiotti. Dr. Kenneth Rankin, who's based in Newcastle University Center for Cancer and North England Bone and Soft Tissue Tumor Service, is an orthopedic oncologist. His research interests include the basic science of musculoskeletal oncology, with a particular interest in osteosarcoma. We welcome you, Dr. Rankin. And then rounding out our expert panel today, we have Dr. Viviana Vitolo, and her work is centered in Pavia, Italy, at the National Center for Oncologic Hadron Therapy. Hadron therapy is a form of radiation therapy that's used to treat tumors that are inoperable or resistant to traditional radiotherapy treatments. And I'm delighted to welcome you, Dr. Vitolo. Clearly, with this excellent panel, I'm quite sure we're all going to learn a great deal from them today. So I would like to just cover, before we begin, a few brief housekeeping tasks. First, the order of our agenda. First, we're going to hear from our speakers, followed by a question and discussion session at the end. So please, you can use the chat box to pose your questions along the way as they occur to you, or if you would like to prefer to hold on to them at the end and then raise your Zoom hand during the discussion, you can pose them live. So without any further delay, I will hand this over to Professor Liegl-Atzwanger to have her start us out. Thank you.
So many thanks for this kind introduction. Today, I would like to talk about the challenges and opportunities of soft tissue sarcoma pathology in 2022. As you all know, sarcoma diagnostic is quite challenging, and this is mainly based on the fact that these tumors are very rare. We have different tumor entities, and the tumors are heterogeneous. Sarcomas account for less than 1% of all malignant tumors. However, we can find it all over the body. And we have to keep in mind that pathologists need to subclassify 70 different sarcoma subtypes. Overall, 9 sarcoma subtypes account for approximately 80 to 82% of our sarcomas. However, the vast majority of sarcoma subtypes are ultra-rare sarcomas with an incidence of less than 1 per 1 million people. So these tumors, in addition, are very heterogeneous on morphology. And so you can appreciate on these pictures that within a lump of one patient, you can find several different morphologic features, and pathologists need to select the adequate immunohistochemistry and molecular stains to confirm that this tumor is a dedifferentiated liposarcoma. In addition, tumors may show quite similar morphology, and here depicted you can see 6 different spindle cell sarcomas which need to be neatly subclassified by immunohistochemistry and molecular diagnostics, because the individual tumor entity becomes an individual treatment in individual cases. So at this point, we have to clarify that sarcoma diagnosis in 2022 needs to include molecular alteration and a good IHC workup for every sarcoma diagnosis and for adequate classification. We have to keep in mind that the group of sarcomas are divided in 2 genetic groups: sarcomas with complex karyotypes and sarcomas with specific genetic alterations, where we mainly focus on translocation-associated sarcomas and sarcomas with specific mutations. And based on the profile, the pathologists have also to pick individual methods to detect the mutations or the fusions which are needed to confirm the diagnosis. Next generation sequencing technologies have massively influenced our work by validation of the classification and also by identification of new, more solid diagnostic markers. And especially these more solid markers have been coming up in the last years more and more by also defining and publishing fusion-specific IHC markers, for example, SS18, SSX, or DDT3 for the diagnosis of synovial sarcoma or myxoid liposarcoma. In addition, with the help of this next generation sequencing technologies, new entities have been discovered. For example, the new group of round blue cell tumors of bone and soft tissue. However, mostly every month, new publications occur with new entities. Identification of new treatment targets are possible with these new technologies, as well as we have learned a lot about the pathobiology. Nevertheless, it's extremely challenging for us to keep up, because it's very hard to keep up with the speed new entities occur. There is also a huge challenge for pathologists based on the promiscuity of gene fusions, because the soft tissue pathologists and also the general pathologists, when using these techniques, need to know when they should use an adequate technique to confirm a diagnosis. So this promiscuity is nicely shown by looking at the EWSR1 gene, which is a gene which can fuse with many different fusion partners. And for example, if somebody thinks that only a breaker part of the EWSR1 gene is diagnostic, then he will be wrong, because it must be a combination of a fluorescence in situ hybridization plus immunohistochemistry and for sure H&E morphology. Even in the case when we know the fusion partner by performing newer technologies like the Archer Fusion Black Sarcoma panel, the fusion alone is not giving us the diagnosis. As you can see, malignant tumors can have this combination out of molecular techniques with morphology and immunohistochemistry. So the burning question, which is asked many times, do you treat somebody based on genotype or phenotype? I think the golden standard for the basis to find the right pathologic diagnosis is a combination of both. Pathologists need to choose the right diagnostic method. And for all of us, I think immunohistochemistry is available. And with some new markers like the SS18 and SSX or the STAT6, it might be possible, even in smaller departments, to have a good workup with an adequate immunohistochemistry. However, you have to keep in mind that we have to confirm these findings by a second approach. For example, a FISH, which is perfectly fine for a synovial sarcoma, or to do a TCPR, a TPCR. However, if you want to find NTRK and NTRK fusions with different partners, this would not be the right technique. So most of the academic centers use now RNA sequencing, and most of them targeted RNA sequencing panels. And I think these panels are a very, very good tool for pathologists to confirm the diagnosis and also to lead prognosis and treatment. So I have picked some examples where I would like to show you the impact on molecular pathology on diagnostic, prognostic, and therapeutic issues. And for example, I picked the spindle and sclerosing rhabdomyosarcoma, which were first introduced to the WHO in 2013. By 2020, the community was able to subclassify these spindle cell and sclerosing rhabdomyosarcomas based mainly on their molecular profile to figure out that we have congenital and spindle cell rhabdomyosarcomas with fusions having an excellent prognosis. However, we face tumors which are also spindle cell and sclerosing rhabdomyosarcomas on morphology, but they show MyoD1 fusions and have a very poor prognosis. And especially Cristina Antonescu and her group worked on these things and were able to find these different subtypes. And in the meantime, even a new entity out of this spindle and sclerosing rhabdomyosarcomas with specific EWSR1 fusions have been reported, especially occurring in the ENT area and the pelvic bones, with a very aggressive behavior and a peculiar immunohistochemical phenotype. So within more or less 1 decade, we can now separate the group of rhabdomyosarcomas in soft tissues very neatly based on their morphology, then their immunohistochemical profile, as well as by including molecular diagnostics in different prognostic groups, a poor prognostic group, a good prognostic group, and tumors with very good prognosis. A highlight of all the work also Cristina Antonescu has done is the molecular classification of the epithelioid vascular tumors. And there is sometimes a huge dilemma in separating epithelioid hemangioma from epithelioid angiosarcoma, especially if these tumors are located in the bone, showing an aggressive radiology or are multifocal. And here, with implementation of molecular techniques, we can now neatly separate these tumors in quite very distinct and molecular proven entities. Also, that subdividing epithelioid hemangioendothelioma makes sense because it has been nicely shown in 2021 that the YAP1 DFA3 epithelioid hemangioendothelioma subtype has a very good prognosis with a 5-year overall survival of 89%. Over the last year, however, we have seen a lot of publications describing spindle cell tumors with benign features, some of them with malignant features, with very overlapping morphology. And I think at this point, we have to state that with the exception of the lipofibromatosis-like neurotumor, which has a quite distinctive morphology, all the other spindle cell tumors, if they have NTRK fusions, RAD fusions, ALK fusions, MAD fusions, RAF fusions, or BRAF fusions, are very, very hardly to distinguish, mainly based on morphology. We have some hints, we have some immunohistochemical stains which help, but at the end of the day, these monotonic spindle cell tumors which have morphologic features of lipofibromatosis-like neurotumor, infantile fibrosarcoma, MPNST, solid fibrous tumor, or IMT, they need extensive molecular testing. By having the fusion, the aim or the duty of the pathologist is to go back to the slides and to decide if this tumor is being put in the benign, in the low grade, or in the high grade category for further treatment. But we should not miss the exact fusion profile, because this has really an impact on the treatment of our patients. We have a lot of learned about the undifferentiated small round cell sarcomas of bone and soft tissue. And I think we all can agree that we have learned a lot, that it's essential to divide the CIC from the Ewing sarcomas and to have the PCOR group. However, there are some issues in the round cell sarcomas with EWSR1, FUS, and non-ETS fusion partners. At least for me, there are some issues which are not clarified yet. So in the other group of Ewing, CIC, PCOR, we really nicely see that this has an impact on dividing these tumors based on their aggressiveness or based if these tumors are chemosensitive or not. However, if we go to the round cell sarcomas with EWSR1 non-ETS fusion partners, the description within the recent WHO is very widely, and there are more tumors which have a more blunt morphology and more or less the mitotic rate is not really good defined. And with these tumors, there are cases like these cases from our department where we have no problem to define this as a sarcoma. However, although Austria is a very small country with 9 million inhabitants, we have encountered within half a year 2 cases which do not fit neatly into this profile. In the meantime, also benign tumors have been reported to have the same fusions, simple bone cysts and vascular tumors. And we have the 2 cases of these young boys with a very peculiar morphology of this histiocyte-rich proliferation with very blunt oval to spindle tumor cells without any really high mitotic count. You find some individual mitosis, and these tumors also show this EWSR1 NFAT-C2 fusion. And the question is, where should we put these cases? They do not look like a solitary bone, a simple bone cyst. They do not look like a high-grade sarcoma. And this is then an interdisciplinary team approach to decide what we should do with this small or young boys, because that has really an impact on their treatment. And I hope that there will be clarification soon. Over the last 2 years, a lot of new sarcoma entities have been described. Here, only some of them written down, where I think that they are extremely essential to diagnose. For example, the NUT-M1 rearranged colorectal sarcoma, which can be easily diagnosed as a carcinoma. So you have to keep in mind to think of this entity, or depicted here, a DICER1 mutated sarcoma with this high-grade spindle cell proliferation and some of the tumor cells with this nice eosinophilic globules. Another new tumor entity has been described and is closing a gap with in the tumors which have morphologic features of fibromyxoid sarcoma and sclerosing epithelioid fibrosarcoma. Here, a new entity has been described with YAP1 KMT2A fusions. And I hope that this small presentation of these different entities showed you that correct classification really matters, because it's the rationale for clinical decision making, it's the rationale to use specific treatments, it's a rationale for prognosis for patients, and it's also predicting treatment response. I think the pathology report needs to be accurate, reliable, and reproducible, and NGS and special techniques really helps us to be reliable and reproducible. And also, what I think is a very good, was a very good effort is that we tried to generate data sets for reporting soft tissue sarcomas together with our clinicians, and pathologists were included for biopsy specimens and resection specimens to be more uniform overall. There is every time the question about the money, but I personally do not want to talk about the money a pathology report costs, because I think that the pathology report is, there is no relationship between what a pathology report costs, even if we do the new techniques in comparison with the treatment. And I think that you don't need the best car if the engine is not working. And so the engine is like the pathology report and the basis for all further steps. And I think this report should be done as good as possible. One of the challenges maybe I would like to face here is to get informed consent. And I hope that there will be more worldwide informed consent we can use from the patients, because for us it's really an issue to send away the tissue of these rare cases. So maybe also the patients' advocacy can help us here to have some input to get this better running. And with this I would like to end, and I would like to focus on the fact that we all have to work together, all clinicians and all the patients, to have the best treatment options for our patients. Thank you very much.
Oh, thank you, Professor Liegl-Atzwanger. That was really an excellent review of molecular pathology and how complex it is and how very, very important it is. So thank you very much. Now I would like to turn our attention towards medical oncology perspective, and I welcome Dr. Stacchiotti. I believe you may be muted.
Can you hear me now?
Yes, yes.
And can you see the slide?
And we see your slides as well. Thank you.
Okay, thank you very much. So first of all, I really would like to thank SPAEN for organizing this meeting and for inviting me, and also for having Bernadette before the eye, as I'm one of the medical oncologists working with sarcoma, who really believes that without a pathologist as a best friend is for us not possible to do a good job. So we are now talking about what is new in the area of soft tissue sarcoma and medical treatment over the last 2 years. Here are my disclosure. And I need to disclose that we will mostly refer to the new version of the ESMO guidelines for treatment of soft tissue sarcoma, which were published in 2021 after a virtual consensus meeting that was done in collaboration with ESMO, Huracan, and Genturis. The general principle for treatment with a systemic agent, soft tissue sarcoma, as nicely presented by Bernadette, starts from the consideration that sarcomas, soft tissue sarcomas, are really an heterogeneous family of tumor, and this heterogeneity reflects into not only morphology and molecular biology, but also in a different sensitivity to systemic agents. Two important papers that were published over the last 2 years are the first one by the French colleagues who refine based on their national database the incidence of all soft tissue sarcomas. And this paper is particularly important as it reports for the first time the European incidence of some very rare sarcoma types, which were identified for the first time over the last 10-15 years. In conjunction with this paper, the community of experts under the umbrella of the Connective Tissue Oncology Society met together and tried to identify the criterion to call a sarcoma an ultra-rare sarcoma. And all the group identify incidence as the criterion to consider, and the incidence of 1 or less than 1 case per 1 million inhabitants per year as the threshold to name a sarcoma type an ultra-rare sarcoma. And this is mostly important for planning, designing new clinical studies, as of course, when a tumor is so rare, it's very difficult to consider, to plan randomized clinical studies. What is also important to notice is that the vast majority of sarcoma types do belong to the group of ultra-rare sarcomas, which means that most of our patients do suffer of a histologic type with an incidence of 1 or less than 1 case per 1 million inhabitants per year. Altogether, ultra-rare sarcomas represent 20% of all soft tissue and all bone sarcomas. And as pointed out before, we have new entities popping up every week, every month. This is not only important for classification, but for treatment. And in fact, I want, for example, to mention this new group of SMARCA4 deficient sarcomas that can arise in the uterus, but also in the thorax, in which the presence of this molecular alteration correspond to a peculiar sensitivity to immunotherapy, as reported recently by Dr. Blais and the French sarcoma group. So this is the case of a very recently identified sarcoma in which in a very short period of time was possibly to see that immunotherapy can work. But we do not know, for example, anything in regard to the activity of a more commonly used agent like doxorubicin or gemcitabine in this histotype. What I mean is that every time pathologists do discover, do define, do present a new entity, us as medical oncology need to go back to all the agents that we have to treat our patient to try to understand if they work or not in this new sarcoma type. In terms of systemic treatment, we need to distinguish soft tissue sarcoma according to their presentation into 3 groups. We have local disease, in which we have the chance of curing our patient. On average, about 60% of patients presenting with a soft tissue sarcoma localized can be cured by our treatment. Then we have the case in which the disease presents presents with isolated lung lesion or isolated metastasis, in this case, there is still a chance of curing patient, even though it is usually considered around 10%. And then we have the case of disease presenting with multiple metastases in which the disease cannot be completely resected. In this case, our goal is not the cure of a patient, but trying to prolong life and to impact in a good way, not in a bad way, the quality of life. In all cases, patients need to be treated after a discussion by the multidisciplinary tumor board within a center of expertise for sarcoma. So let's try to see what is new for treatment of primary localized disease. If you can look at the flowchart that is presented in the ESMO guidelines, you see that systemic treatment plays a limited role, as in fact surgery and radiation therapy do represent the standard treatment in this setting. Then we need to distinguish two different roles for chemotherapy or systemic treatment in primary localized disease. We can have the cases in which we need a cytoreduction to help surgical resection. In this case, we talk of cytoreductive systemic treatment, and preoperative systemic treatment aimed at reducing the tumor has always to be considered a standard. While the name adjuvant or neoadjuvant treatment is appropriate for those cases in which the treatment is aimed at reducing the risk of systemic relapse of a tumor that can be completely resected even without any medical treatment. So, as far as neoadjuvant systemic treatment is concerned, in 2020 were published the results of a European multicentric study, randomized study, in which a patient with an high-grade, deeply located, more than 5 centimeter primary localized soft tissue sarcoma were treated with a full dose regimen, including anthracycline and ifosfamide, versus a histology tailored regimen, which was selected according to diagnosis in a different way for leiomyosarcoma, myxoid liposarcoma, synovial sarcoma, and PNST and pleomorphic sarcoma, of course in combination with a complete surgical resection and radiation therapy. This study did not provide definitive results, but showed a trend in favor of a better outcome for patients treated with the combination of anthracyclines together with ifosfamide compared to histology tailored regimen. And when we use the nomogram circulator to stratify further high-risk patient compared to lower-risk patient, was significantly detected a difference between those treated with anthracycline versus histology tailored regimen, with a benefit, a significant benefit for patients with high-risk disease compared to lower-risk disease, when high-risk disease is a risk of metastatic spread at 10 years of 40% or more. Based on these results in the ESMO guidelines, and the last version, it is presented neoadjuvant chemotherapy not as a standard, but as an option in high-risk patient where the risk is defined according to circulators, 10 years predicted overall survival of less than 60%. with a regimen including full dose doxorubicin or epirubicin plus ifosfamide for 3 cycles administered preoperatively. With regard to cases presenting with advanced oligometastatic disease, there are no major changes. The standard treatment is still represented by surgery that can be anticipated by preoperative systemic chemotherapy. In the advanced disease, the first-line regimen is still represented by anthracycline-based chemotherapy. Anthracycline can be used in monotherapy or in combination according to the aim of the treatment. An important paper was published by the ERTC presenting the results of a retrospective study in which in leiomyosarcoma was investigated the activity of the combination doxorubicin or anthracycline and ifosfamide versus anthracycline and dacarbazine and anthracycline alone. And this paper, although with all the limit of a retrospective analysis, showed clearly that the combination of anthracycline and dacarbazine is the one with the best anti-tumor effect, both in terms of response rate and progression-free survival and also overall survival. So we can say today that in front line in soft tissue sarcoma with metastatic disease, the treatment of choice is adramycin or adramycin plus ifosfamide or adramycin plus dacarbazine, and the regimen has to be selected according to prior treatment, to the condition of the patient, and to the reason for which the chemotherapy is given. In case we need a major tumor shrinkage, is usually better a combination, even though it can be more toxic. When there is the need of a disease control, the monotherapy can also be enough. And of course, we need to take into consideration histology. As we saw, there are combinations like adramycin, dacarbazine that can be more active in histologic type like leiomyosarcoma or solitary fibrous tumor, while other like adramycin, ifosfamide that can be more active in a histologic type like, for example, MPNST. There are some exceptions in which the first-line treatment is not chemotherapy with doxorubicin anthracycline-based chemotherapy, but are target agents, and this is the case of imatinib in dermatofibrous sarcoma protuberans and of NTRK inhibitors in NTRK fused sarcoma. Then there are histologic type in which chemotherapy with doxorubicin has no activity, like alveolar soft part sarcoma or epithelioid hemangiosarcoma, in which other agents are of course better, like anti-angiogenic or sirolimus. And unfortunately, these compounds are not approved, formally labeled, and for that reason, there is a huge difference in the potential access and use of these compounds across countries. And this is an example of a very good response to the NTRK inhibitor larotrectinib in a patient with a locally advanced disease that after the response to treatment could be resected with a conservative surgical resection. In case we need a treatment after the use of doxorubicin, anthracycline base, so in further line for advanced disease, the selection of the best regimen has to be based on histologic diagnosis. And this raises again the importance of a correct pathologic diagnosis, as pathologic diagnosis is so far the best predictor of a response to the agents available for treatment of sarcoma. We have a list of drugs that are approved by EMA in second line for treatment of sarcoma. And we have also 3 new compounds: tazemetostat for epithelioid sarcoma, pexidartinib for tenosynovial giant cell tumor, and nab-sirolimus for PEComa. All these three compounds have been approved by FDA over the last year and a half. Unfortunately, they have not been approved by EMA, and for that reason, they are not available for treatment of this sarcoma type in Europe and in several other countries outside the US. Then we have a list of potentially active agents that are not formally labeled by EMA, but neither by FDA, that can, of course, be considered as there are evidence of activity in selected histologic type. So what is new with regard to cytotoxic chemotherapy in further line for advanced soft tissue sarcoma? We have not new drugs, but we have a better refinement of how to use old, well-known drug in selected sarcoma types. And so I want to highlight, for example, this patient showing that trabectedin can be active in the deep liposarcoma, especially when the grade of the disease is low. And so this compound that is formally approved for all soft tissue sarcoma in a second line is not active in all soft tissue sarcoma. We need to select the correct one. We know that it works in myxoid liposarcoma. We know that it works in leiomyosarcoma, but we know that there are also specific settings like low-grade deep liposarcoma or, for example, solitary fibrous tumor in which the compound can be used. Then we have data on the activity of trabectedin in combination with radiation therapy. This is a study, phase 1/2 study conducted in Europe with the group, started from the group, the Spanish sarcoma group, that showed a very strong radio sensitizer effect provided by trabectedin with very good responses. And then there are papers like this one showing that conventional chemotherapy, anthracycline-based chemotherapy, but also combination with methotrexate vinorelbine, can work very well in, for example, myofibroblastic inflammatory tumor. This is again to underline that every time we have a new sarcoma, a rare sarcoma that was not specifically investigated for the activity of conventional chemotherapy, is important to go back and see if this drug can be of help. You see the response here to methotrexate vinorelbine was really very good. And similarly, we had a paper published last year in which the same combination was found to be effective in desmoid fibromatosis related to familial adenomatosis polyposis. With regard to tyrosine kinase inhibitor, we had the report of the activity of pexidartinib in tenosynovial giant cell tumor at a longer follow-up, showing that this compound can basically provide a response in almost all patients treated with this drug. Then we had a very interesting result of a prospective phase 2 single-arm study investigating nab-sirolimus in PEComa. And what also this paper was able to provide was not only that the majority of patients are sensitive to this class of compound, which was already known, but also pointed out that the activity of this class of agent depends on the mutation to TSC1 or TSC2 that can be seen in a patient, not all PEComa patients, but most patients with PEComa, with the TSC2 mutation being the most sensitive to the activity of nab-sirolimus. As said, based on these results, nab-sirolimus has been approved by FDA, while it is not available in Europe and in several other countries. However, sirolimus can be a valid alternative. Then we had also the publication of a retrospective study on the activity again of sirolimus in epithelioid hemangioendothelioma, an orphan tumor for which no active compound are formally approved, in which sirolimus can provide a disease stabilization in a previously progressive patient in more than 50% of the cases, but with no activity seen in the most aggressive variant with serosal effusion. What is important to notice is that the translocation that characterizes epithelioid hemangioendothelioma is responsible for the activation of the Hippo pathway, and in particular for the hyperexpression of T, the protein responsible for gene transcription, and new compounds and new studies are coming able to target TID, and we really hope that this can represent a new avenue for epithelioid hemangioendothelioma patient. Then we had also the publication of a study on pazopanib in solitary fibrous tumor, showing that this drug can be active not only in the intermediate grade, but also in the low grade advanced solitary fibrous tumor, while we knew from the first paper that pazopanib is not active in the differentiated variant of the disease. With regard to immunotherapy, again, unfortunately, the access to immunotherapy is very limited for sarcoma patients outside clinical study. Only pembrolizumab is formally labeled for those sarcoma in which there is a microsatellite instability, which is a very rare event in a soft tissue sarcoma. We know that overall the results observed with immunotherapy in sarcoma are disappointing. There are only to now a few histologic type of interest, but we have to say that the majority is still left to be investigated. And as said, in most cases, the availability of PD-1, PD-L1, and other immune agent is provided only within clinical study, with only few studies, unfortunately, ongoing in Europe. And at least for now, again, also to immunotherapy, the best predictor of response is represented by histology. So which are the soft tissue sarcoma types for which there is at least some clinical evidence of sensitivity to immune agents? They are synovial sarcoma and myxoid liposarcoma, to T-cell therapies, still investigational, targeting NY-ESO and major T. Then there are relevant data, interesting, very important data on the activity of PD-1, PD-L1 inhibitor in alveolar self-part sarcoma and angiosarcoma. To a lower extent, the same class of agent, both as monotherapy and in combination, has been shown to have some activity in the differentiated liposarcoma and in UPS. And then in a long list of sarcoma types in which there are case reports or very small series, like myxofibrous sarcoma, clear cell sarcoma, epithelioid sarcoma, and as mentioned before, SMARCA4 deficient sarcoma. This is the example of a study on alveolar soft-part sarcoma in which the PD-L1 inhibitor geptalonimab was investigated by our Chinese colleague, showing activity. Unfortunately, none of the PD-1, PD-L1 inhibitor investigated so far is formally approved in the disease. And now, going to the end, I want to again recall that we cannot mention all histologic type, but pathologic classification is very important. And the last example is represented by synovial sarcoma, in which very recently was found that the presence of the translocation is responsible for SMARCB1 alteration. this creates a perturbation of the BAF system and makes synovial sarcoma dependent from the protein of the BAF system called BRD9. This protein now can be targeted with different compounds that are started to be investigated within a phase 1 study that will involve several sites across the world, across for sure US and Europe, and we really hope that this will provide a new perspective for patients. And with that, I want to thank you for the attention, and I'm available for all question and discussion. Thank you.
Thank you, Dr. Stacchiotti. Clearly, you showed us how important the molecular pathology is to laying the groundwork for the medical oncology perspective, and thank you for outlining how those guidelines were formulated and based on such systematic review of the important research that was done. So now we're going to turn our attention towards a surgeon's perspective, and Dr. Rankin, we look forward to hearing from you.
Hello, yes. Can you see my slides?
Yes, we can see your slides. And we can hear you well.
Yes, okay, good. Yes, so I'm going to give you a surgeon's perspective on soft tissue sarcoma. So I'm based in the north of England, and that's my disclaimer there. A paid consultant of Stryker, one of the companies that make infrared cameras. So I trained in orthopedic surgery. You probably are aware that sarcoma surgeons are quite unusual. I think if you ask most of them, they didn't plan to become a sarcoma surgery early on in their career at medical school or even as a junior doctor. And so sarcoma surgeons usually are inspired by a mentor, and they originate from orthopedics, plastic surgery. Then we have surgical oncologists who do a range of cancer work, which includes doing sarcoma surgery. And similarly with children, you have children cancer surgeons or pediatric cancer surgeons who deal with sarcoma patients as part of a broader cancer practice. So as an orthopedic surgeon, becoming more interested in cancer surgery and obviously sarcoma, I deal with obviously bone sarcoma and also bone spread from other cancers. But of course, I deal with soft tissue sarcoma. So then I have to put the saws and hammers away and have to be very delicate and more like a plastic surgeon. And we develop different skill sets to try to remove a soft tissue sarcoma. And what we want to do is to remove it with what we call a clear margin. And one of the things when you start to become more and more interested as a surgeon in sarcoma is how confusing it is. And so as you probably know, the WHO have a classification of soft tissue and bone tumors, and it is all very confusing. And obviously that's why we are highly dependent on our pathologists, as you've heard before. They are always meeting and refining the classifications, and we've had a really clear talk about that. So as the surgeon, what you're then doing is you're obviously planning to do an operation at some point. And so, but you have to think about what other treatments the patient often does have. And I'm sure, again, you'll be aware that most soft tissue sarcoma patients will have some radiotherapy, unless their tumor is very small and low grade. So, and then there's a lot of discussions about whether the radiotherapy should be before or after surgery. That has quite a big impact on what happens with wound healing. And then, of course, we've heard lots of detail about chemotherapy, and that could be given before or after surgery. It might be given before and after surgery. Then the other things that we think about, and there's probably not enough work done on this is this concept of what we call prehabilitation. So you want to try and have your soft tissue sarcoma patient in the best sort of mental state, and actually physical fitness. We know from other common cancer types, or more common cancer types, that physical fitness can improve outcomes for patients. And so actually, I think there's a need for more prehabilitation programs prior to undertaking the operation. And then, of course, post-operative rehabilitation is a subject in its own right, but it does link into, obviously, the scale of the surgery that we do. So the aim of surgery, as I mentioned, was obviously we want to remove the sarcoma with what we call clear margins. So we obviously don't want to leave any of the sarcoma cells behind, because it would be more likely to come back. But there's a balance between doing that and not removing so much normal tissue around it unnecessarily. So we have to think quite hard about what we're doing. And then once we've removed the sarcoma, then we have to think about the reconstruction. That might be as simple as just stitching the wound closed and putting a dressing on it, or it could be something extremely complicated. There may be that we take some bone away with a soft tissue sarcoma. We have to reconstruct the bone. We have to reconstruct the soft tissues. All sarcoma services will have input from plastic surgeons to reconstruct repair the soft tissues. And what we want to do is get a reconstruction that hopefully reduces early problems for the patient, such as wound infections. And also we want the best long-term function for the patient. So there's a lot to think about when we are planning the surgery. In terms of what we mean when we talk about getting clear margins, these graphs essentially show that if you have a positive margin after the surgery, so once the sarcoma is removed, obviously it goes to the pathologist who will tell you about the margins. And if, unfortunately, the margin is positive, then we know, so the graph on the left, the blue line is showing that the patients are more likely to have the sarcoma coming back, so local recurrence. And the gap between the lines here, patients who have had clear margins, is very clear. And it also can impact on the patient's survival chances. So that here the blue line is lower because actually the survival can be worse if the patient has a positive margin. So our job as a surgeon is really important to try and get that clear margin. And then, as again, you'll know this, I'm sure, that the difficulty is each patient's sarcoma is unique. That makes it, of course, very interesting from the point of view of a surgeon. We have to have a specific plan for each patient. It might be a small sarcoma on a finger, for example, although relative to the finger, it's actually quite big. It might be a big sarcoma in the thigh, like this one. Here's one on the chest wall. And we have to think about what other structures is it near a big important nerve or blood vessel. And so even though the type of sarcoma may be the same in a couple of patients, where it is in the patient can make a huge difference to the operation you end up doing. So I just I put up an alert here for the next slide, because obviously it's a surgical talk, so I will show some images from operations. So the next image really is showing, just to get a sort of scale of some of these sarcomas. So this is the soft tissue sarcoma that we have removed from the thigh of a patient. And so the ruler there is 15 centimeters. What you'll also notice then is there's an area of skin, there's some fat here, and there's some muscle. And so when we do this operation, we do not want to see that sarcoma. We don't want to look at it in the eye, as it were, because we want to make sure we clear it with a covering of normal tissue. And just put an American football here just for a bit of a scale of size, really big, and obviously has a major impact on the patient's function afterwards. And so when that sarcoma goes to the pathologist, we are then in the MDT a week or two later, and the surgeon will be anxious, very anxious with all the colleagues around, because as you're aware, we need lots of colleagues to get the right treatment plan for a patient. And when we're discussing margins of a sarcoma, then we're very nervous to hear about it, and our colleagues will often start asking detailed questions about what we're going to do if the margin is positive. So in terms of the surgery, what do we have? We have preoperative planning. Obviously, we are heavily dependent on MRI scans. We might also get CT scans if the bone is involved. And if the sarcoma is particularly difficult, we actually often have what we call an imaging meeting. So we sit down separately to the multidisciplinary meeting. We sit down, make time separately with radiologists, and sometimes we might bring in a vascular surgeon or a urology surgeon who's not a sarcoma surgeon, but is going to help us with some aspect if it's a particularly awkward, difficult sarcoma in terms of removing. And then when we're ready to do the operation on the day, we have a clear briefing to the team. And then I would like to show you some recent advances in terms of what we can use to help us attain that goal of getting the soft tissue sarcoma out without leaving any behind, getting those clear margins. So we can use computer navigation for bone cuts, but it's quite rare, obviously, to do that for a soft tissue sarcoma. However, we've done quite a large series now of something called fluorescence guided surgery, and I'll show you some of this. So this is an example of a soft tissue sarcoma in the pelvis. So it's sitting on the inner side of the pelvic bone and above the hip joint, and I've sort of put a line around it there. And this is an example where, to get the clear margin, we're going to take some bone, and that's what we've done. And then when we've done a reconstruction for this patient, we've used some screws and rods, as you can see there, and then the patient actually is done reasonably well in terms of function. However, what we've been doing more recently is using a dye called indocyanine green. This dye has been around for decades. It makes tissues glow, and we hit upon the concept that actually, if we gave it to patients before the surgery, the afternoon before surgery in most cases, that perhaps the sarcomas would glow, and it has worked, and we've been doing this for the last 3 years or so. The Game Changers, one of the companies, produced this, what we call infrared camera. So it looks like a barcode scanner, but actually when you're operating, you can pick it up and have a look. And if you're getting close to the tumor will glow through the normal tissue. And so you get a sense that you're getting too close. So we give the dye the day before surgery in most cases. And so again, just an alert for the next slide is the first case that it worked well on. That's me holding the camera and pointing it down and showing it that the tumor is glowing there. And then when we start to use all of the technologies together, this is another sarcoma, soft tissue sarcoma in the pelvis. This time it's on the outside of the bone, the pelvic bone, and I've shown it outlined there with a red line. And so this is one of my colleagues, and he's doing the computer navigation plan, which will help us do the bone cuts. And that's him painting the tumor yellow on the MRI scan. And then we plan the bone cuts off the CT scan. And then this is, and again, an alert for the next slide, this is showing the sarcoma when we're removing it. And here we're using the camera to look at an area we think we're getting close. So the camera has a normal light. So you can see here, basically, my fingers are holding some muscle. And then actually, when we've put the camera into infrared mode, I hope you can appreciate that this area looks quite green. And that's actually because we're getting a bit too close to the sarcoma. We're not in the sarcoma, because it would be very bright green if we actually went into it. But it's getting a bit green, and that gives us a warning we're getting too close. And so what we do is take more muscle, and then you can see this is the normal light, and then on the bottom right is the actually infrared. You can see it's not so green, and that's because we've improved that margin in that area. And that's the concept that we've been working on. And this is the sarcoma removed, and on the left is the normal light, and the right is the infrared mode. And you can see there's no startling green areas, which is good. And we've got a piece of bone on part of it, and that's where we've used computer navigation to take a section of bone. So, as I said, over the last 3 years, we've been doing these cases with fluorescence-guided surgery. And when we compared to patients who had not had fluorescence-guided surgery, what we found is basically we looked at our series. We had 76 patients who had conventional surgery and 39 that had fluorescence-guided surgery. And that was really down to the availability of the dye and the camera system. Now we tend to use it all the time. 2/3 of the patients had soft tissue sarcomas. Most of these soft tissue sarcomas were glowing. And in about 1/4 of the cases, the surgeons reported using that dye and the camera helped. Even more importantly, the margin rates were better in the fluorescence-guided surgery group. So 1 in 20, so 5% versus 1 in 4 actually in the conventional surgery group, which is quite high for that series. But actually then hopefully that gives better outcomes to our patients. And so going off this work, we've actually spent a couple of years putting together an application for a randomized controlled trial where we will, across the United Kingdom, recruit patients to receive fluorescence-guided surgery or conventional surgery. And I'm just anxiously awaiting the outcome of that, which will be any day now. And hopefully, if it works well, then this would become standard practice. We can also look at the fluorescent dye under the microscope. So one of the companies produces a slide scanner. And this is actually a case here where we're able to look at the tumor and we're able to look across into the margin of the tumor. And we can actually zoom down into a high power and we can see the dye in the sarcoma cells. It also collects in areas where the tumor is bled within itself. So actually, we're getting some interesting data looking at the dye, and we are collaborating with our pathologists. It's opened up a whole area of work. We also have a lab group, so we can do some cell work, growing cells at a dish. So this is a picture here. The pictures here, the breast cancer cell and the cells on the left grow slowly, and the sarcoma cells on the right grow quickly, and they take up more of the dye. We put the dye on overnight. And we've been able to show that the faster a cell grows, the more dye it takes up. And that's actually quite a nice model of a high-grade sarcoma versus a lower-grade sarcoma. And we have found when we tried to use the dye in patients with a low-grade soft tissue sarcoma, it doesn't really help because we think that the sarcoma is not so active and doesn't take up so much dye. And we've been able to look at exactly how the cells take up the dye, and there's a special cellular pathway, and we can block that pathway and demonstrate that we actually are understanding how the dye works in sarcoma cells. And then moving on from that, we want to use something that's a bit better than the ICG. So again, working with our pathologists, we validated a sarcoma marker we call MT1-MMP. There are therapeutics that have been designed against MT1-MMP. And then from the surgical angle, you can see here very clearly, this is a patient who had a myxofibrosarcoma, which was invading into normal tissue nearby. And we've managed to stain the cells brown, the sarcoma cells up staining brown with immunohistochemistry and using an antibody against MT1-MMP. And taking that a step forward, we've been labeling the antibody with infrared dye and also a radiotracer called zirconium. And the idea would be that ultimately we would be able to use this for PET MRI imaging for preoperative planning, and also the infrared dye 800. We would be able to use that with the same camera that we currently use. And so we're working on bringing this to the clinic. So in summary, sarcoma surgery is complex and challenging. I hope I've convinced you we are starting to improve our techniques so that we can get better outcomes and better function for our patients. So thank you. Obviously, thanks to our patients who've been involved in our studies. There's lots of people who have been involved in the lab and also looking at clinical data. And of course, our MDT that actually is flexible and gives me time to do some of the research that a lot of my surgical colleagues just can't find the time to do. We also have a cancer trials team that designed the trial, and we've had input from one of the camera companies and funding from Orthopedic Research UK is one of our charities. Thank you, that's it.
Thank you, Dr. Rankin. That was really an excellent talk, and really helps us to see that relation of the surgeon within that multidisciplinary team. I think we all hear about how important it is, and you really demonstrated that for us, as well as I think we've also heard about margins, but a picture's worth 1,000 words. And so it was nice to be able to visualize what oftentimes people explain to us. So thank you so much. And now we're going to turn our attention to our last perspective that we're going to hear from, the perspective of radiation oncology. And Dr. Vitolo, we'll turn to you.
Okay.
I see your screen.
Okay, can you see it? Okay.
Yes, and we can hear you as well.
I can. Okay, perfect. Just a second. Okay, so thanks for this nice invitation and the opportunity to be here this evening. I have no conflict of interest to declare. So I will discuss about the role of radiation therapy in soft tissue sarcoma, and discussing about the timing of radiation therapy, preoperative or postoperative radiation therapy, the potential benefits of the modern radiation therapy techniques. My presentation will be based on the recent updated guideline by the ESMO and on the guideline from the American Society for Radiation Oncologists. So what is the role of radiation therapy in this complex disease? Is to help the surgeon to obtain F0 resection margins. So is to decrease the risk of local recurrence. We know that before to treat a patient with this kind of disease, it's necessary to define the risk of local recurrence. And this is a complex process, which is, and the risk of local recurrence is related to several factors. So the discussion among the specialists has the role to investigate and to define such risk. Now in our era, now nomograms can help us to better define such risk. But each case has to be discussed, even to define how to integrate all the possible treatment modalities for patients. Here you see one of the possible nomograms that help us to define such local recurrence risk. We have two scenarios to define the role of radiation therapy together with the other treatment modalities. And in case of localized disease, when the disease is resectable, we have to consider the grade of the disease. For low-grade disease, radiation therapy has a marginal role and can be prescribed, but this after discussion for each singular case. In high-grade disease has a more important role and can be prescribed in preoperative setting or in postoperative setting in case of positive margin, especially when the surgeon decide that there is no the opportunity to make a new resection, especially and if preoperative radiation therapy was not given before. In case of unresectable disease, radiation therapy finds its role together with chemotherapy, as already discussed before, or alone as the only possible local treatment. Historically, in the literature, we know that for extremities of tissue sarcomas, the role of neoadjuvant radiation therapy is to increase the F0 resection rate.
And as already discussed, R0 margin is also related to a good prognosis for patient. This is a large study, a database in which were analyzed the patient treated with the preoperative radiation therapy versus patient treated without any radiation therapy, and it's clear that the benefit in terms of R0 resection margin. About the timing of treatment. Now the approach is to prefer the preoperative radiation therapy instead of the postoperative radiation therapy, because has been seen that even if the result in terms of local control and so the prognosis of patient are similar, preoperative radiation therapy has the advantage to give less toxicity. It's real that the potential risk of preoperative radiation therapy is a higher risk of major bone complication, but this can be solved while the side effects of postoperative radiation therapy can be present also during the time. So these studies show very clearly how preoperative radiation therapy has to be preferred over postoperative radiation therapy, and this is a phase 3 study which compared two groups of patients treated with both modalities, and the conclusions are clear. So postoperative radiation therapy give much more toxicity. These data are related to all the radiation therapy technique, are referred to 3D conformal radiation therapy technique. And here in this table, you can see the percentage of toxicity after postoperative radiation therapy. Now we can see in this other slide that modern radiation therapy technique decrease the risk of toxicity, because now using a modern radiation therapy technique and what is called image guide radiation therapy, so we can obtain a better result in terms of side effects. Modern radiation therapy technique allows to deliver a more conformal dose to the target, so allow us to create a small target volume, and also the possibility to check every day volumetric images of the patient, offer also the possibility to detect possible volumetric changes of the tumor during treatment and to replan the treatment. So we also can see here in this retrospective analysis how modern radiation therapy technique such as the IMRT allow to obtain a better result, not only in terms of side effects, but also in terms of control of the disease, so of the prognosis of patient. This image show very clearly how the evolution of radiation therapy allow to better spare organ at risk, in this case especially the bone. So the risk of bone fracture, for instance, is reduced by this new approach. Radiation oncologist has now guideline which show us what kind of dose we can deliver to the organ at risk, because toxicity is well known to be related to release dose. So we know that we can release to the bone a certain dose, expecting reduced toxicity. Also, guidelines suggest to the radiation oncologist how to define the volume, the treatment volume, so which kind of sequences of the MRI to use to define the gross tumor volume, how is defined, what kind of margin to use to include in the treatment volume the microscopic disease, and then we have an additional volume to define the planning target volume, which is related to the technique we are using for the delivery, and which is has to be considered smaller as much the technique is more sophisticated and the setup of patient is more well defined. A different or a similar, I would say, approach for another location of soft tissue sarcoma, retroperitoneal sarcoma, again, preoperative radiation therapy with conventional fractionation is what is generally suggested by the guidelines. Post-operative radiation therapy for this kind of location is discouraged because of the possible toxicity risk. When the surgeon removes this big mass in the retroperitoneal space, after surgery, the bowel loops go very close, move very close to the surgical bed. So to deliver the high dose necessary to sterilize the surgical bed can be at risk for the bowel, for the bowels, and so for the toxicity there. In some experienced centers, preoperative radiation therapy is delivered with a concomitant boost. So it's delivered a simultaneous boost of radiation therapy in the posterior region of the lesion where possibly are expected positive margins. A recent articles comparing for retroperitoneal sarcoma, preoperative radiation therapy and surgery versus surgery alone show how preoperative radiation therapy is not beneficial for all subtype of histology, but especially for liposarcoma subgroup of patients. Discussing about the advanced radiation therapy techniques, one of the opportunity we have now is particle therapy. So we were saying before that IMRT, so the intensity modulated radiation therapy, as a more conformal technique, has the opportunity to better spare normal tissue. Particle therapy, based on the physical properties of the particle, have a greater advantage in terms of selectivity and so in terms of sparing of the surrounding organs at risk. On the other side, and in addition, particles such as carbon ions radiation therapy, based on the bigger mass and of the charge, has biologically the opportunity to be more aggressive against the tumor. Is still limited the experience for retroperitoneal sarcomas, especially with particles, but there are some studies still recruiting patients where this kind of treatment is employed to try to have a better result in terms of resecability and negative margins, for instance, for retroperitoneal sarcoma. Here, when you see the red area, the idea is to increase the dose in such region to obtain R0 resection margin. This is the typical area where possibly the surgeon can obtain positive margin. So the idea is to increase the dose to have a better result and to help the surgeon. This study is still recruiting patients, so we have to see the result. The other similar approach still for retroperitoneal sarcoma is the use of particle therapy, both protons or carbon ion radiation therapy in the preoperative setting to see if there is any kind of difference for the surgeon, and to test in this phase 2 study the potential incident of toxicity as the primary endpoint, and the possible local control rate as a secondary endpoint. The other scenario to consider then for the role of radiation therapy is when the disease is unresectable. So here, radiation therapy, as we were saying before, is possible together with chemotherapy, but is the only possible local treatment to suggest to the patient. The experience in such scenario is not so extensive, and data are still limited to very few patients treated in Japan with exclusive carbon ion radiation therapy treatment for retroperitoneal sarcoma located with, I would say, a good anatomical location, so quite distant to the bowel loops that we are saying are the critical point for radiation oncologists. And in this small study with different histological subtype considered, colleagues had good encouraging results in terms of local control and survival with very low toxicity. So just to conclude, radiation therapy for sure represent an important role together with the other treatment modalities in this challenging treatment of this disease. Generally, new guidelines suggest that preoperative radiation therapy is to be preferred over postoperative radiation therapy, especially for the toxicity, and in this setting, modern radiation therapy option can improve the outcome of patient in terms of toxicity, but also in terms of prognosis. Of course, the multidisciplinary approach to the patient is necessary, and for sure we have to define new studies to validate also the role of these new radiation therapy delivery techniques, and possible also new fractionation schemes. And thanks for listening.
Thank you, Dr. Vitolo, for that excellent talk and for helping us to understand what are some of the refinements and advancements in radiation that are improving outcomes and reducing toxicity. Obviously, to patients and families, that's so important, good outcomes and manageable toxicity. So with that, I know we're coming close to the end of our time, over that we have several questions in the chat. Panelists, are you okay to stay for just a bit to answer a few questions? That would be terrific. So let me open up our chat. I don't know if each of you as the speakers can see that, but we have Andrea asking, is there a role for pathologists in the analysis of the tumor microenvironment, as this entity is becoming more and more important in the field of immunotherapy, precision oncology for solid tumor?
So I'm aware of these studies which are looking for like the CD4, the CD8 cells and the macrophages within the tumor. And also there have been studies published on like genes involving this tumor microenvironment. I personally do not think that we really are able to count all these single inflammatory cells on a H&E slide and be very, very accurate. So I think if there is a role for pathologists, you have to combine this with digital intelligence and special stains, and then give really good quotes of these tumor inflammatory lymphocytes. but maybe the molecular basis and gene signatures, we will see more. But I personally have not tried a lot of these stainings with inflammatory cells.
Thank you. Dr. Stacchiotti, you had mentioned about there were some drugs that were not approved by the EMA, but were approved by the FDA. And Andrea asked about if there's a role for SPAEN or patient advocacy in general to help push to make more drugs available. Is there a role for the patient advocates in SPAEN to do that?
Yeah, of course, there is always a very important role. And I think that patient advocates should be always part of the discussion. In these particular cases, with regard to tazemetostat and pexidartinib, I'm sorry, but I'm not very optimistic about succeeding with EMA unless the companies decide to go back with new data about toxicity and activity, which is probably not going to be the case here. But in general, yes, I think that the role of patient is really, really very important.
So lending our voice to say that these are important advances that we want to see available for patients. It's a different perspective than the physicians that are treating. So, yeah.
If I may maybe add to that, what Silvia just said is the example of pexidartinib, EMA has actually had a hearing which involved patient advocates from SPAEN. But unfortunately, obviously, we couldn't make our point, but we actually advocated for this compound to be approved in the EU, but EMA decided otherwise. So, but yes, there are possibilities to be involved in such a process. Yes.
I think being persistent as well, right? So that was, even if it doesn't work the first time, to continue to persist. Dr. Stacchiotti, you were going to say?
No, I'm saying that in this particular case, the role of patient advocates was surely the one to try to move a bit forward the discussion. So EMA would have stopped considering the drug before without patient. However, they didn't consider toxicity good enough to allow the use of the drug. But I'm sure that everything we do together in terms of consensus of paper, position paper, editorials, and effort to inform the regulatory bodies of how a disease is made, which is the prognosis, collecting data, and so on, in collaboration with patients, is really very important. Without that, we are probably not going to get any new compound for ultra-rare sarcoma, because in terms of economic value, they do not count too much.
Yeah. Excellent, thank you. For you, Dr. Rankin, there was a question about the use of acridine orange in the setting of phytodynamic surgery for sarcomas. Do you have an opinion about this technique?
Yeah, thank you for the question. I hadn't heard of it, so you always learn something, isn't it, doing these sessions. So I looked it up, obviously. I think my opinion would be the wavelength is lower than the indocyanine green. So basically, if you're trying to use an infrared camera, the tissue penetration from the tumor through normal tissue will not be as good as indocyanine green, which is why we use indocyanine green. However, I mean, it's something I'll certainly look into in more detail. Because there must be a utility there if they're trying it, but it's that's actually helpful for me to have a look at as well.
Thank you. Dr. Vitolo, do you see that there's a question for you around the role and effectiveness of particle radiotherapy in lungs for metastatic disease?
So generally is not there is no indication to use particle therapy. Technically, it's feasible, but when in oligometastatic disease, when we discuss patient with such diagnosis, the first option is to resect such metastases, if possible, if considered feasible, and generally is prescribed stereotactic radiation therapy. The indication for particle therapy are still limited, and to date, even if it's feasible, there is no evidence of a major benefit in case of metastasis, of the singular metastasis. It's also a question of cost for the national health system, I would say. Particle therapy to date is generally used as a possible alternative to surgery when still the tumor is localized in the primary site. This is the main indication. I don't exclude that in the future there will be a place for particle therapy if in some such situations, but not now, not yet.
Thank you. And I think that, oh, go ahead.
No, if I may add, in terms of differential diagnosis, usually sarcoma metastases to the lung are nodular and are different from infective lesion. In any case, it's absolutely true that following up our patient during this COVID period, we discover lung infection, of which we were not aware before. But usually after some antibiotic and a new CT can be distinguished easily if this was an infection or a lung metastasis.
It's appropriate that we unfortunately are still with this COVID and that we have a question to end our session today about what impact it's having on kind of tracking patients and trying to discern between metastatic disease and small nodules that are COVID. So, well, I appreciate everybody staying a bit longer today and for all of your time and for the excellent presentations. Our panelists, I thank you so much for making time to share your valuable perspectives. And for everybody who joined our session today, we're most appreciative because obviously we couldn't do it without the participation of all of you. So thank you very much.
Thanks to you for being here with us.
Thank you very much for taking the time. Wonderful presentations.
See you soon.
Take care. Goodbye.
Thanks to all of you. Bye-bye.
Thank you.
Bye-bye.